Hi there, welcome to this warm-up review. Let's get started. First question. Which disorder is associated with each of the following findings? So pathology of thyroid cells with optically clear nuclei. These are your orphan antinuclei, seen with papillary carcinoma of the thyroid. Anemia with hypersegmented neutrophils. This is the classic megaloblastic anemia of vitamin B12 and folate deficiency. Next would be branching rods on oral infection. So we see that with Actinomyces israelii. Next, eczema, recurrent infections, and thrombocytopenia. So Wader was a mnemonic for this one, for Wiskott-Aldrich syndrome. Next would be hemosideruria and thrombosis. This is what you see with paroxysmal nocturnal hemoglobinuria, or PNH. Next question. Which stage of sleep is associated with each of the following EEG findings? So first would be your alpha waves. This signifies relaxation. So not really a sleep stage, but you see alpha waves as you're relaxing and about to go to sleep. And stage N1 might have alpha waves, but stage N1 is indicated by one of the answers here below, which is theta waves. Next is beta waves, which indicate REM sleep. Delta waves indicate stage N3. And then finally, as I said, theta waves are stage N1. Okay, that's it for this warm-up review. Let's move on to the lecture.
We've talked about how platelets work. Now let's talk about diseases where the platelets don't work, either because there aren't enough platelets or because the platelets that are there are somehow defective. These platelet disorders are very high yield. You should expect several questions on these. First off, how do platelet disorders present? Well, obviously there's going to be bleeding, but specifically you're going to see microhemorrhages. We said that coagulopathies and disorders of the coagulation cascade tend to cause macrohemorrhages, but platelet disorders tend to cause microhemorrhages, such as bleeding from the mucous membranes, epistaxis, which is nosebleeds, and petechiae, which are those tiny little dots on the skin from capillary hemorrhage. They're not raised or palpable, they're just flat brown or red dots, a lot like freckles. Those are petechiae. Or you can have purpura, which are larger hemorrhages under the skin. So microhemorrhages are the classic presentation for platelet disorders. And then on the labs, we've said that since the platelet plug is the first step in hemostasis, with platelet dysfunction, you're going to have an increased bleeding time. But if the coagulation cascade is normal, the PT and INR and PTT should all be normal. Now, there are 4 pure platelet disorders that we're going to discuss, and they're definitely high yield. This is a 4-star topic. You're going to have a question on at least one of these platelet disorders. I want to talk about the 2 more common ones first, ITP and TTP. So the first one is ITP, or immune thrombocytopenia. It used to be called immune thrombocytopenic purpura. Before that it was called idiopathic thrombocytopenic purpura. So you may see those older names from time to time. But this is not an idiopathic disease. This is an autoimmune disease where you have autoantibodies to glycoprotein 2b3a. So these antibodies bind to 2b3a on the surface of the platelets, and then the immune system removes and destroys those platelets. So the platelet count is going to be low, and if you did a bone marrow biopsy, you would see increased megakaryocytes because the bone marrow is trying to churn out more platelets. I also think it's worth knowing how we treat ITP. It's an autoimmune disease, and in general, how do we treat autoimmune disease? We use steroids. So you can use steroids to treat this. You can also use IV immunoglobulin, better known as IVIG. You could also do a splenectomy, so you remove the spleen. Remember, about 1/3 of your platelets are stored or sequestered in the spleen. So if you surgically remove the spleen, that allows more platelets to be in circulation because you're not sequestering them in the spleen. The second platelet disorder I want to cover is TTP, or thrombotic thrombocytopenic purpura. So this is basically a thrombotic disease. The platelets are being excessively activated and they're aggregating, so you're going to have widespread platelet thrombosis. And all that unregulated thrombosis uses up all the platelets. So there's subsequently thrombocytopenia. And then because you've used up all the platelets, you have bleeding and purpura. So again, it's thrombotic thrombocytopenic purpura. Let's look at the pathophysiology in a little more detail because we can tie it into the platelet activation mechanism that we've already discussed. Take a look in the study guide. What's the underlying pathophysiology in TTP? Well, you have a deficiency of a metalloprotease called ADAMTS13. What on earth is that? That stands for a disintegrin and metalloprotease with thrombospondin type 1 motif, number 13. I'm sure that makes it totally clear. This is a zinc-containing enzyme, so it's a metalloprotease, and it cleaves the von Willebrand factor multimers into the smaller active von Willebrand factor units. So remember, when you have an endothelial injury, von Willebrand factor is released. But actually, the von Willebrand factor in the endothelial cells is assembled into large multimers. Then these have to be cleaved into the smaller individual von Willebrand factor units by this ADAMTS13 protease. So in TTP, you have a deficiency of this metalloprotease, so the von Willebrand factor multimers can't be broken down, and these multimers can bind to platelets and cause unregulated platelet aggregation. And again, your platelets are being consumed, so you have thrombocytopenia. Then you also have some activation of the coagulation cascade, and all that excessive coagulation and fibrin mesh within the vessels will cause microangiopathic hemolytic anemia. And we talked about how things like TTP and DIC could potentially cause microangiopathic hemolytic anemia with intravascular hemolysis and schistocytes and elevated LDH. TTP is closely related to another condition called HUS, or hemolytic uremic syndrome. Now, some experts consider these to be two parts of a continuous spectrum of one disease process, while other experts talk about these as distinct entities. But you can think about HUS as being kind of a milder form of TTP. So let's talk about the clinical picture of TTP and HUS together. In the study guide it says, what's the classic triad of findings in HUS and the classic pentad of TTP? So with hemolytic uremic syndrome, you have hemolysis, we just saw that, and it's hemolytic uremic syndrome, so you're going to have some uremia and renal insufficiency. And then you also have thrombocytopenia, because the platelets are aggregating like crazy and they're getting used up. So with both HUS and TTP, you have those three things: hemolytic anemia, uremia, and thrombocytopenia. And then with TTP, you add neurological symptoms, things like confusion, headache, seizures, coma, maybe even some rare focal deficits that look a lot like a stroke, and you add fever. Now, recent studies are suggesting that high fever may actually be fairly uncommon with TTP, but it's still part of that classic pentad. Now, there are several decent mnemonics to help you remember all five of those features. One mnemonic is FAT-RN, which lots of students seem to like. FAT-RN stands for fever, anemia, thrombocytopenia, renal failure, and neurological symptoms. And then last year, a student from PNWU came up with the mnemonic HUNT for the toilet paper, where HUNT for is hemolysis, uremia, neurological symptoms, thrombocytopenia, and fever. And then it's HUNT for the toilet paper. So the toilet paper stands for TTP. Not bad. But I prefer the mnemonic nasty fever torched his kidneys, because it talks about fever and talks about torching the kidneys. So that's two of the symptoms right there. And you know I love mnemonics that actually mention what you're trying to memorize. So nasty fever torched his kidneys stands for neurological symptoms, fever, thrombocytopenia, hemolysis, and then the kidneys is for kidney failure. But whichever mnemonic you prefer, you need to know that HUS is the milder form with the triad of hemolysis, uremia, and thrombocytopenia, and then TTP is more severe because you've gone from a triad to a pentad. Now, it's relatively rare to see all of those symptoms at the same time. Early on, all you may see is some thrombocytopenia and that microangiopathic hemolysis. Some people will say that if the neurological abnormalities are dominant, it's TTP. If the renal failure and uremia are the dominant presentation, it's hemolytic uremic syndrome. And then one more thing to file away is that in children, HUS is associated with E. coli O157H7 infection. So definitely know that. Our third platelet disorder to discuss is Bernard-Soulier syndrome. Now this one is very rare. About 1 in a million people have it. It's caused by a defect of glycoprotein 1b, which you remember is what binds the platelet to the von Willebrand factor and to the subendothelial collagen. So the platelet can't bind to collagen, there's going to be a defect of platelet plug formation. Now these platelets are also enlarged and they get taken out of circulation, so there's a moderate thrombocytopenia. So the platelet count is decreased and the bleeding time is prolonged. All of these platelet disorders cause prolonged bleeding time, right? But here, the bleeding is actually more of a platelet dysfunction rather than merely a platelet deficiency. With ITP and with TTP, you have that thrombocytopenia. So you can look at the CBC and see that the platelet count is low. But with Bernard-Soulier, the platelet count is only slightly low. The number of platelets isn't too bad, but those platelets that you do have are defective. And then our fourth platelet disorder is called Glanzmann's thrombasthenia. This is a defect in glycoprotein 2b3a. So what platelet process will that affect? Aggregation. Platelet adhesion is normal, platelet activation is normal, but the platelets can't aggregate normally. So here the platelet count is normal, there's no thrombocytopenia. But the bleeding time is still going to be increased because again, without platelet aggregation, you can't form a platelet plug. So bleeding time is prolonged. So again, those are your four major pure platelet disorders: ITP, TTP, Bernard-Soulier syndrome, and Glanzmann thrombasthenia. Very high yield. Then I also want to remind you of a couple of other situations where you might have some thrombocytopenia. We talked about heparin-induced thrombocytopenia. We also talked about with aplastic anemia, you can have some thrombocytopenia because with aplastic anemia, the bone marrow stops making everything. Now let's look at some mixed platelet and coagulation disorders. These are diseases that affect both the platelets and the coagulation cascade. Let's start with von Willebrand disease, which is the most common inherited bleeding disorder. It's more common than hemophilia. It's much more common than those other hereditary bleeding disorders we talked about, like Glanzmann thrombocythemia or Bernard-Soulier syndrome. So von Willebrand disease is a defect of von Willebrand factor. We talked about how von Willebrand factor does two things. It stabilizes and protects factor VIII, so a von Willebrand factor deficiency is going to increase PTT, and it binds to the subendothelial collagen and to glycoprotein 1b on platelets. So if that doesn't happen, the platelets can't adhere to the vessel wall and you'll have prolonged bleeding time. So that's why this is one of the mixed disorders. It affects both the coagulation cascade and platelet function. Now, to diagnose von Willebrand disease, you can measure the von Willebrand factor level, you can measure the factor VIII activity, or you can do a ristocetin cofactor assay. And that's the diagnosis you're most likely to see on step 1. Ristocetin is a substance that causes platelets to agglutinate if von Willebrand factor is present. So if you take the patient's blood and you add ristocetin and the platelets agglutinate, that means the patient's blood does contain von Willebrand factor. But if there's no agglutination, that's positive for von Willebrand disease. And then the treatment is something you'll never be able to reason out in a million years. You just have to memorize it. For von Willebrand disease, we give DDAVP, or desmopressin, which is a synthetic form of antidiuretic hormone. ADH increases the release of von Willebrand factor from storage sites in the endothelial cells. So you give DDAVP, more von Willebrand factor can be released. Then the other mixed disorder is DIC, or disseminated intravascular coagulation. Now DIC is a terrible disease, very, very life-threatening. Like the name suggests, you have this widespread activation of clotting. So you're consuming all your platelets and you're consuming all your coagulation factors. So even though the underlying pathology is coagulation, the clinical result is that you're hypocoagulable, so you're going to have more bleeding, somewhat like TTP in that regard. You have low platelets because they're being consumed, and that causes a prolonged bleeding time. But the coagulation factors are also being consumed, so PT and PTT are also going to be prolonged. This is a real mess. You can also see low fibrinogen, which is a very good clue on the labs, and it's very high yield. Now, why would DIC cause low fibrinogen? Well, because fibrinogen is being used up, just like the platelets are being used up and the other clotting factors. You might see high fibrin split products or high D-dimer. D-dimers or fibrin split products are protein fragments that are left over when you break down fibrin. So your body's having to break down all those widespread clots, and that's going to cause an elevated D-dimer. And then on peripheral smear, you might see schistocytes from that microangiopathic hemolytic anemia. And then you should know clinically DIC can present with bleeding, obviously, and also multi-organ failure. It's important to remember the potential causes of DIC. And there's a good mnemonic for this one too. Stop making thrombi. That stands for sepsis, which is classically gram-negative sepsis, but any kind of sepsis can do it. Trauma, obstetric complications, especially amniotic fluid embolism or abruptio placentae. So anytime you see a postpartum patient with excessive bleeding, think about the possibility of DIC. Acute pancreatitis can cause DIC. So the P is for pancreatitis. And then the M in making is for malignancy, and the T in thrombi is for transfusion. So definitely know those causes of DIC. Stop making thrombi. Again, I love it when a mnemonic is linked to the subject you're learning. Now, for years, this mnemonic has been taught as stop making new thrombi, where that N in new was supposed to stand for nephrotic syndrome, but I haven't been able to find any good data to back that up. Let's wrap up with a whiteboard review. We've covered 6 different platelet disorders in this video. So let's match the underlying pathophysiologies over on the left with the names of the disorders on the right. So the first one, we have anti-glycoprotein 2B3A antibodies, and those are seen in ITP, those patients with immune thrombocytopenia. Then ADAMTS13 deficiency, we said was associated with TTP-HUS. Glycoprotein 1B defects are seen in Bernard-Soulier syndrome. Then glycoprotein 2B3A defects are seen in Glanzmann's thrombocythemia. Then obviously von Willebrand factor defect is associated with von Willebrand disease. And widespread activation of platelets and the coagulation cascade is DIC. So let's also think about which of these diseases are going to present as chronic platelet disorders and which ones are going to be more acute illnesses. So first of all, genetic disorders are generally going to be chronic, right? So which of these are due to genetic defects? Well, von Willebrand factor is generally genetic. That means it's going to be chronic. And so is Bernard-Soulier syndrome and Glanzmann's thrombocythemia. Now, ITP isn't necessarily genetic, but it is a chronic disease. Generally, these patients are going to settle at a stable platelet count without needing any ongoing chronic treatment. But very few of these patients have a true spontaneous remission, so it is a chronic disease. And then TTP and HUS is generally an acute disease, and so is DIC. And both of these have very high mortality unless these are recognized and treated. All right, let's go ahead and tackle the end of session quiz. All right, first question. What is the cause of ITP? Well, it's caused by antibodies against glycoprotein 2b3a on platelets. And those antibodies bind to the platelets, and then the platelet antibody complexes get removed from circulation. Next, what's the defect in Bernard-Soulier disease? That's a deficiency of glycoprotein 1b, so the platelets can't bind to collagen very well. And the last question, after a normal spontaneous vaginal delivery, a new mom bleeds profusely from her vagina and then later from her gums. So what abnormal lab values would you suspect? Well, the gum bleeding is very suspicious. That tells you this is more than just postpartum hemorrhage. This is DIC. Remember we said obstetric complications such as amniotic fluid embolism or placental abruption can sometimes cause DIC. It's very important to be able to recognize DIC from the labs. So the labs are going to show increased bleeding time, increased PT and PTT, decreased platelets, high D-dimer, and decreased fibrinogen. All right, that's the end of the quiz. So let's go ahead and go through these rapid-fire facts quickly, and then we'll be all done. So antiplatelet antibodies are associated again with immune thrombocytopenia. Bleeding disorder with glycoprotein 1b deficiency is Bernard-Soulier disease. And the most common inherited bleeding disorder is von Willebrand disease. That's it for now. I'll see you next time.